Hello class, I am Dr. Upasna, and today we have this short primer session for the checklist in oral cavity malignancy in CT imaging. And in future we will have the detailed discussion in which we will describe the optimal CT protocol parameters for oral cavity cancer imaging, in which we will describe contrast timing, slice thickness and reconstructions important for the oral cavity cancer imaging. And we will identify the oral cavity squamous carcinoma and correlate with AGCC 8th edition TNM imaging staging. And here I will share with you the short structured reporting checklist covering the tumor site extent and bone invasion nodal status with extranodal extension. So the important thing is the site of the tumor and the site of the invasion matters in the oral cavity, and in that the most important one is retromolar trigon. Why it matters on CT is because if this retromolar trigon is involved, or indirectly it says that pterygomandibular raphe is involved. So from here the tumor can spread to the mandible. It will involve the mandible, and through this pterygo it can also extends along the mesenteric space, and important thing is it can go posteriorly. So once this is involved, we consider it that there will be posterior extension of this tumor beyond the oral cavity. Means it has extended into the oropharynx, or we will evaluate whether it has extended into mesenteric space or mandibular involvement is there or not. So this is one important key point. Next is the measurement of depth of invasion. So there is one term, that is the interpreted mucosal line. Now here you can see in this blue that this is whole the extent of the tumor. Okay. Now if I have to measure the line, measure the depth, then I will consider this as the surface line, and from here I will draw perpendicular line and extend this line till the maximum surface it has involved, at the periphery of the maximum surface it has involved. So this is where it is this is where we measure the depth of invasion. This is what we call the depth of invasion. So it is important because when the true surface is distorted, especially in ulcer, when you will see that there is a crater and this is there, then you will interpret this as a mucosal surface, as this was the mucosal surface, but due to ulceration and everything this has regressed. So from here you will calculate the depth of invasion. So irregular tumor contour, in practice you draw the line from the expected intact mucosa till the basement membrane of the adjacent normal mucosa, and then measure it perpendicular to the deepest point of the tumor infiltration. The most important thing in the oral cavity is the pattern of spread. There are three patterns. One is directly the tumor can extend into the mesenteric and all those spaces, adjacent spaces, lymphatic spread by lymph nodes, and neurovascular. The most important thing is you have to know all the foramens in the oral cavity, near to the oral cavity, because the most possible thing you have to rule out is the neurovascular extension, because from the nerves and vessels it can extend into the intracranial spaces. And the clinical history, which is important and which is a clue for you to visualize this in the CT, that if patient complains of the paresthesia over face, then it suggests some nerve involvement, and you have to look for inferior alveolar nerve, gingivobuccal sulcus, where this inferior alveolar nerve is usually present, where this canal is there in sagittal bone reconstruction. So this we will see in detail in future sessions. And the important thing is the staging, because what happens whether the patient has to be given palliative treatment or surgical treatment, it depends till how much the extent of involvement is. So there is one term that is the supranotch versus infranotch, and it is important because you have to decide whether mandibulectomy versus maxillectomy with the pterygopalatine fossa clearance. This is very important. So the worst prognosis is if it has extended to supranotch. The resectability of the infranotch is usually very curable, but advanced supranotch often we can't get R0 resection. So there are chances that there will be residual tumor and thus the recurrence. These are the various pathways, and what is the main difference if the supranotch is involved, which foramen to look for, and if infranotch is involved, which foramen to look for. Main thing is the pterygopalatine fossa around which all the foramen is there. So you have to look that superiorly it is extending to the anteriorly to the orbital, that is periorbital spread by infraorbital foramen rotundum, then pterygomaxillary fissure, then sphenopalatine foramen, Vidian canal, and the inferiorly it goes to the greater palatine and hard palate. So sometimes there will be involvement in the oral cavity, but you will see that there the hard palate mucosal thickening is also there. So you have to look for that whether there is a greater palatine canal widening is there or not. So next is the osseous, that is the bony involvement. So important thing is in you should get the city bone window, and in that the other important maneuver is the cheek maneuver, in which you ask the person, puff cheek maneuver, that is you ask the person to to uh, do the Valsalva maneuver, and in that we perform either one of the phases, venous phases especially, and this is to detect any lesions which has overlapped by the soft tissue like mandibular, maxillary, gingivo-buccal sulcus, and especially the hard palate, which is very important. So always in the history, after the history you got to know that okay, there is some lesion in the oral cavity, always examine and try to get the images in the puffed cheek maneuver, and which critically influence the staging and the surgical management of the patient. So what it helps in, the puff cheek technique helps to separate the buccal mucosa from gingivo-buccal sulcus. And the next thing is important for mandible segmentectomy is the mandibular height involvement. So if the invasion is involving more than the 50% vertical height of the inferior cortex, there then it favors the segmental mandibulectomy. So always we have to describe the which site is involved, whether alveolus is involved, body is involved, or angle is involved, and whether the invasion is cortical or medullary. In this mostly we advise MRI T1 sequence and to see to confirm the extent till the medullary in some cases. Vertical extent relative to the mandibular height and inferior cortical involvement is important. So in short, the checklist is the primary site, whether it is a buccal mucosa, whether it is a retromolar trigone or pterygomandibular raphe. So what all is involved? This is important. And next is the pattern of spread, and you have to look for various foramen to rule out perineural spread. Then you have to look at extranodal extension, and before that you have to know that what all lymph nodes could be involved. So we have to know the stations of the lymph node, that level 1, then level 2, 1A, 1B, that and retropharyngeal nodes you have to look for. You have to look for level 3, and the abnormal lymph node criteria is that whether there is a heterogeneous enhancement. With peripheral you will see that there is hyper enhancement, there is necrotic areas, and in between, and you will see a lot of fat stranding. So this is suggestive of extranodal extension. So these are the features of extranodal extension. Next, osseous involvement with mandibular height is important, and you have to rule out whether the supranotch is involved by looking at the maxillary fissure, pterygopalatine fossa, sphenopalatine foramen, and this involvement is important. And infranotch involvement, what are they spread anteriorly and posteriorly. So here this is just a crisp and short session for the checklist of the CT imaging in oral cavity malignancy. Thank you.